How does thinking behind suicide prevention change with age? I think that what you do for children in a school is clearly going to be different from how you address suicidal behavior or risk in adults. Again, the destigmatization is a common theme, but I think that perhaps getting in early in high school in dealing with things, as I said, like bullying and providing much more better support early on will be a better investment to try and minimize subsequent suicidal behavior. We've also been interested in the relationship between suicide and pain. And it does seem that people with serious suicidal ideation and active intent have a higher threshold for physical pain. They don't seem to be able to recognize the physical pain. It's almost like the circuits that are preoccupied with the sense of despair and wish to be dead override the circuits of physical pain. So we're looking at some of these measures in people with depression. Biomarkers are essentially any kind of biological measures that can be used in a number of different ways. So, for example, to distinguish people who have a certain risk factor for a disorder from those who don't. They could be blood samples that could look at genetic or protein measures, or they could be brain imaging measures, or they could even be a combination of more than one. Biomarkers can also be used to stage a disorder, or they could be used, as we're looking at, to help us to separate subgroups within what we call major depressive disorder and identify optimal treatments. So, for example, it does appear that some people may have increased activity in certain brain circuits that might make them good candidates for an antidepressant treatment, while others actually, if anything, have a lower activity in the same regions, and they may be better candidates, for example, for a cognitive therapy or other treatment. So we're looking at relatively large samples with collaborators right across Canada in our CanBind group to look at the predictors of response to a single antidepressant medication, and for those who don't respond, the effect of adding some adjunctive medication as a first study. We're also looking at prediction of response to neurostimulation with transcranial magnetic stimulation, or RTMS. And we're beginning to look at cognitive behavior therapy and the potential to identify biomarkers. The hope would be that in a number of years' time, people could have a simple, relatively inexpensive test or battery of tests that would be quickly analyzed and would allow the physician or the treatment team to say, we've done the workup and this is the treatment that we recommend. So that if today our first-line treatments get people into remission about 40% of the time, we would be looking to see if we could double that and give people more like a 4 out of 5 chance. In psychiatry, one of the few times when a biomarker can be directly accessed from the brain is in those who have completed suicide. So while it's a sad event, it does allow groups like our collaborators in McGill University with Professor Gustavo Turecki to look at the brains of recently completed suicide individuals who can be matched against those who, for example, may have died under accidental circumstances in a car accident. And we can actually begin to see some of the epigenetic markers which reflect the influence of stress on genetic material, often early in life, as being different in the suicide group. So we are beginning to ask questions that hopefully, led by the University of Toronto and collaboration with other sites across Ontario and across Canada and internationally, will help to identify more focused treatments for people who have serious risk of suicide.